I am Frederick Seifer. I am a pulmonologist, and I work in upstate New York. The county that I'm in is St. Lawrence County, and it's very sparsely populated. So in this huge geography, there's only about 120,000 covered lives. I have many patients who do not have internet, do not have Wi-Fi. I have some patients who don't even have phones. So this geography and the fact that the patients are so spread out does make it challenging sometimes to have FaceTime with these patients. And right now, because of the pandemic and because of the winter, I would say about 95% of my practice right now is remote. So I have an open and honest communication with all my patients, which then is the foundation of mutual accountability, which is then the foundation of our entire relationship moving forward as provider and patient. An important part of mutual accountability is to explain. So many of my patients, because they have advanced lung disease, they're on multiple medications and sometimes multiple what I call widgets, devices. You have a much better chance of a patient being compliant with a medication or with a device or with advice if they understand why they're doing those things. So when I am evaluating a patient for therapy, I have to consider who is the patient, where are they in the arc of their disease, and what are their challenges, their insecurities. Can they get around? Do they have a car? Can they get to my office? And then there's also things like food insecurity. I mean, I have patients that have to make a decision whether they're going to eat or they're going to take their medicine, which is unbelievable. I have some patients that don't even have electricity. They get their power through a generator. So, you really need to know where your patient is at before you start throwing therapies at them that are not practical. With the advent of new telehealth technologies, I've been able to really augment my ability to provide service to my rural, resource-limited population. So anytime something new emerges, I have to ask myself this question. And I think it's a real important question that healthcare needs to ask itself. Is there a real need for this? Is this something that adds value to what is currently available? And anytime there's change in anyone's lives, I don't care if it's a patient or a provider, that creates uncertainty. Uncertainty creates anxiety. So I do not want to introduce anything to a patient, whether it's an inhaler, a medication, a widget, a device, including a remote patient monitoring device, unless I think this has the potential to add value to my ability to take better care of this patient. Now I think I've onboarded probably 60 patients with remote patient monitoring technology. There are so many isms. What do I mean by that? Well, there's racism and there's sexism and there's all these isms. And there's also something I call ruralism. There is this this preconception that if you live in a rural community, that you are not just challenged in the ways we've been talking about in terms of food insecurities or travel, but that you're challenged in other ways which are not necessarily true, like intellect, education, motivation. And interestingly, I think this bias against rural communities is reflected in clinical research that's performed. So when I started doing this project with the remote patient monitoring device, there was this perception that I was going to have a harder time onboarding my patients and have a harder time keeping these patients engaged. That is, to keep them compliant. What I have found is that individuals living in a rural community will step to the plate. They want to be involved. They want to contribute. They want to make a difference. And it's really going to come down to education. I go, there you are, and I sit down and I listen. I want to listen to you because I got to know where you live. I got to know what's important to you. I need to know something about you so that I can make my pitch to you contextualized to where you're at. So listening is very important. And if you listen many times, patients will say something, but you go, but what's behind that? What's behind that? What's behind that? I've actually had patients say to me, Dr. Steve, you don't just listen to what I'm saying, you're listening to what's behind what I'm saying. And that just, it makes me all warm and mushy inside because they know what I'm doing. Do I think telehealth adds value to my practice and my ability to take better care of my patients? I do, absolutely. I also believe that, this is a fact. Right now in the United States, there's maybe 12,000 pulmonologists. That's it. There are maybe 15 million people with COPD, another, 12 million people with, quote, asthma, and then you've got all kinds of other pulmonary diseases. The point I'm making is telehealth is certainly one of those ways to bridge that gap to specialists like pulmonologists, especially in rural communities. So telehealth adds value to the provider, myself, gives me another parameter, another touch point, another safety net, certainly for my staff, for the same reasons, but also if telehealth reduces anxiety for my patients, then that's less phone calls for my staff to field. The patient reps take the calls, and the nurses take the calls. And frankly, while they're taking those calls to mitigate patient anxiety, which is important, they can't be doing other things that they need to do. So it certainly helps the workflow. What's the margin part of this? Well, imagine that you, over time, can take better care of your patients and save healthcare dollars. That's what is they call the triple aim. I do believe that over time, what I'm going to show or find is that because I can intervene earlier, it requires less intervention. I believe over time, I'm going to demonstrate that I can manage these patients with less antibiotics. In the literature, firmly established, everyone agrees that the more frequent the exacerbations of the COPD, but as important, if not more important, the more severe the exacerbation, the faster the decline in lung function. Now, anytime you put a patient on an antibiotic, you put pressure on the pathogens in their ecosystem. And over time, these patients develop multi-drug resistant bacteria, which is alone has been associated as a negative prognostic sign and a faster deterioration in lung function, and shortened, certainly worsening quality of life, and probably shortening of the life. If you can demonstrate that RPM, because you can intervene sooner, earlier, then you can get the person back where they need to be with less intervention, less antibiotics, less steroids, then that's huge. Because that is absolutely huge, because you haven't proven it at this point, but if you can reduce steroid pressure and reduce antibiotic pressure, it's likely that you're going to reduce the onset of multi-drug resistant bacteria, and that you could actually mitigate that decline in lung function. That would be absolutely a grand slam.
Innovation and you, Philips.